How's everybody doing today? It's Saturday of Tree Fort. As you can see, I'm sitting down. My legs are like rubber. It's been a really fun weekend. I hope you guys have been having fun at Hackfort, and super happy to have my friend AJ here and Anson. You're going to be talking on rural healthcare, and just some of the really cool things that they're working on to help improve access to a lot of these communities and help out. So super excited, and I will have the microphone for Q&A. So AJ, I'll turn it over to you, buddy.
All right, thank you guys for being here this morning on an early Saturday. I know a lot of people probably had a real long night last night. Part of my visual here is I'm not as tech savvy as most of the people here at Hackfort and Tree Fort. So I was trying to figure out how to open this up. So we'll start off with we're going to talk about rural health and telehealth and telemedicine, the difference between the two. Primarily why I got into this industry, and I'll give you a little background on myself and how I ended up falling into this, was drug overdoses. So as drug overdoses have become more prevalent because of fentanyl fills, which fentanyl was a cheap opioid being distributed by China back in 2013, 2012. So it's been around for well over 9-10 years. I had a personal friend of mine who was a victim of this and ended up passing. And he had taken a Percocet off the street that was cut with cheap fentanyl and never woke up. And it's more common than you think, because it's been happening quite often. It's cut with everything, so they're literally flooding the street. And I met Dr. Moyse, and Dr. Moyse had introduced me to his brother as they were doing a clinic in Lenore, North Carolina, that was for behavioral health therapy and substance abuse, basically to intervene, so preventative care. And we teamed up, and they all got licensed in the state of Arizona, which is where our clinic is for A New Direction. And it's still flush to reason, so we've only been up for about 3-4 months, and that's all that it is. So we have a clinic out there called A New Direction in Flagstaff, and we're focusing on the rural communities as far as the tribal villages and areas that primarily wouldn't be able to have access to something of this sort, or even close access. When I was in Lenore, I spoke to a gentleman because I was at their clinic. I was doing some training. I was getting up to speed on how things worked. When I was in Lenore, I spoke to a gentleman that traveled 5 hours round trip to get to the clinic. So awesome. Thank you. That's why you guys are here. So he traveled 5 hours round trip to get this clinic to get his medication. And I was baffled, because he said he'd only be able to make it out there twice a month. Between his family, they were sharing one vehicle. So he had to wait till dad was off of work off his night late shift, and then he would be on the road by 7, try to get to his appointment by 10:30. But God forbid something happened on the road, he wouldn't make it on time, and so on. So here comes along why we speak about rural health and why it's important. So according to the FDA, rural health is people living in rural areas, obviously not urban areas, who are generally located farther from healthcare facilities and other services than people living in urban areas. Rural residents tend to be older and are at higher risk for poor health and then outcomes than urban residents. So about 20% of our population is in rural areas. A lot of them don't have access to healthcare facilities or even specialized healthcare. So fun fact, not necessarily fun, but compared to urban residents, people living in rural areas are more likely to die from heart disease, cancer, unintentional injury, chronic lower respiratory disease, and stroke. People in rural areas tend to not have as much, time to do physical activity because they're working longer hours. A lot of them working in agricultural. They tend to drink more and smoke more. So, difference between telehealth and telemedicine. Telehealth refers to a broader scope of remote healthcare services than telemedicine. Telemedicine refers specifically to remote clinical services, while telehealth can refer to remote non-clinical services. So telehealth would be two physicians across the country that are sharing information in regard to a certain case that they can speak via Zoom, via web, via phone chat, etc. And it's not anything new. So, telehealth has been around for well over decades. 1906 when the electrocardiogram was introduced and published. The gentleman that introduced electrocardiogram had published a paper on telecardiogram. Excuse me. In the 20s, we were using radios to give information to ships as far as their clinics and what information can be provided to be able to provide health on the ship itself. For the doctors that may not be as well versed in the specific case or something that may have occurred during that time on the ship. Excuse me. So in 2002, Medicare established Telehealth to be a part of their distribution network for health-related services and information and telecommunication technologies. So once Medicare was accepting this as a norm, the health industry started saying, okay, well, maybe this is something we can go to. Still didn't become adopted. Now we come pre-pandemic, which, with COVID going on, it was more of a norm to be able to see your doctor across from a screen versus actually going in person and seeing him and going to the clinic and making a visit and adopt, so on. So with telehealth, it allows a patient to be able to see a doctor without having to actually drive the distance or having to take the time to, allot 6-7 hours of their time to be able to go make this round trip to a clinic to maybe see a doctor for about 5 or 10 minutes. So it gives us more access to be able to help the population that doesn't have access to our urban and major hospitals and specialized hospitals to be able to get their healthcare management. And it allows a lot for the patient and clinician contact advice, reminders, education, intervention, monitoring, and remote admissions. Not only along with just a patient, but these doctors are able to do training scenarios with different clinicians and physicians and everyone else in the healthcare spectrum. So they no longer have to leave the comfort of their own home. In most cases, if a doctor's work in a state, they have to be licensed in that state. So as long as the doctor's licensed in that state, they can be in the middle of, Bermuda, or they can be off in the Galapagos Islands, as long as they have Wi-Fi and internet access so they can speak to that patient. So again, telehealth is nothing new. As we're going here post-pandemic, we are becoming more adapted to it and it's becoming more norm. So a lot of the hospitals are now taking into account that, hey, you know what, this actually might be a good thing for us. Where a doctor no longer has to utilize as much time to spend, 10, 15 minutes walking from floor to floor to go see a patient. They can sit in the comfort of their office and able to see, 20, 30, 40 patients in a matter of an hour, which is improving their time utilized versus how much billable hours they're doing to see 10 patients for the same allotted time. Let me just do that again. Okay, so a couple of facts again from the FDA site here. So rural health is the health of people living in rural areas, as we just said, who are generally located farther from healthcare facilities. So rural areas tend to have people that are higher rates of who do not have health insurance or who have limited access to healthcare services because many have medical centers in rural areas are closing. There isn't enough budget to keep these places open if there isn't enough people coming through. So if you have, a population of less than 1,000 people, no one's going to go and say, hey, let's build a hospital here and take care of this group of people because there's no profit in it. And that's the sad thing is most of our healthcare is profit driven here in the States. So with these satellite offices that could be built, as we did, we opened an office out in Flagstaff. And again, we're focusing on the communities that don't have access to us. We've literally set up in there and just made sure our Wi-Fi is working. We've put good functioning computers. So our patients are able to see a doctor that is, 300-400 miles away or 2,000 miles away. And in these rural areas, most of the people that are at risk of these health disparities are poor Latino Hispanics, African Americans, poor whites, Indian Alaska Natives, and Native Americans. Again, the lower health access, a lot of these people don't have 3, 4 multiple cars. So it's a family of 6 to 8 people that are sharing one vehicle. that's very difficult to manage as far as appointment times and being able to get someone to the hospital or get someone to their specialist. As we grow and it becomes more adapted, I believe that things like physical therapy and being able to tie into another talk we're having here later this afternoon, virtual worlds are going to be applied and combined. So you'll be able to see your physical therapist in the comfort of your own living room, where he's coming up and you're literally like, hey, wake up, you're late for your appointment. And they're able to do that physical therapy while being viewed through something that we all have every day that we're constantly using, is our phone. So everyone has their handheld phone. We all have access to that phone as long as we're within a Wi-Fi range. And that's the future. I mean, that's where we're going. That's the direction we're in. So again, things like monitoring every day. So versus a patient that has to go in 2-3 times in a clinic or has to monitor their blood pressure, their heart rate, or their O2 saturation. There's more devices that are being made friendly for people to take home and use in the comfort of their own home, where that data is then reported and collected to whatever software may be tied into it. Most EHRs or electronic health records are now being that they're web-based, I feel will be transitioning to IO and Android in the coming years, in the next 1 to 3 to 5 years. Want to chime in a little bit? Or?
Oh, well, sure.
This is Dr. Moyes. He was doing a talk here yesterday, but he is one of my providers at our clinic in New Direction, so I'll let him speak a little bit.
Well, yeah. Good morning. I think it's still morning. Well, yeah. I'm Dr. Anson Moyes. I'm a board-certified anesthesiologist and pain management physician and certified addiction specialist. I've been taking part in telemedicine for about 5 years now. I'm based in New Jersey, but I have licenses in New York, New Jersey, North Carolina, Tennessee, and Arizona, and ultimately I working my way into Idaho. What I've done over these past 5 years with my brother, who's a gastroenterologist, but also a certified addiction specialist, is create a substance abuse clinic, which provides counseling, testing, as well as medication supplementation based treatment for people with opioid abuse disorder. And I remember about a year ago, I was telling AJ about my practice in North Carolina, which it serves about 1,000 patients right now between myself, my brother. Believe it or not, I have a cousin who's a surgeon who is also in the clinic and a nurse practitioner in the practice. So we between the four of us, we see about 1,000 patients, and they're coming from all over in the rural area. They're coming from Virginia. They're coming from South Carolina, Georgia, to the office because that's the only place that they would have a provider. And I live all the way out in New Jersey, so my office hours, they'll come to Lenoir, North Carolina, which is a tiny little town in North Carolina. They'll come to the office, they'll have their counseling, and then they'll be put in front of a computer. And when they get in front of the computer, they'll see one of the providers, either myself or whoever it is that's their dedicated provider. And I was telling AJ about this about a year ago, and then he was mentioning how big of a need and how tremendous the opioid deaths were in Arizona. So we decided to find a location, and he went out and he vetted a few locations, and we came up with Flagstaff, and we're just trying to build awareness and get these patients out there. Challenges that creates is we're all East Coast providers, but now we're dealing with Pacific schedules, which is fine. It just takes a little bit more time, but I'll start my day seeing my regular patients in the office, and then in the afternoon, I may go get on the computer and see my Lenoir patients, and then into the evening. Now, 5 o'clock Pacific time is now about 8 o'clock when I'll start the Arizona clinic. But I mean, the need is there, so we try to do our best to serve the community as best as we can. Our goal is to obviously get more providers, hopefully some providers on the West Coast as well, to help join us, and just to scale the amount of awareness and scale the practice to serve a community that's really in need. People are dying, families' lives are getting destroyed because of this, the opioid epidemic, and it's really important to have people aware that there is help out there, and thankfully we have AJ, who's been really paramount in getting the people aware in that Flagstaff community, and then from there we'll expand onward. So, I mean, the telemedicine space has gotten so much better since 2000, the early 2000s. Even when I started in 2017, insurance companies just weren't recognizing the benefit of telemedicine. They want the patients in the office. They want the doctor's hands on the patients, and in order for them to consider that a legit visit. But I was telling Ron over here, one of the worst things that you can say is a good thing that happened from COVID, but it is really a great thing that happened as a result of COVID, is out of necessity, people are recognizing the benefits of telemedicine and being able to stay in your home to make your appointments. So it's only going to get better. We have that panel in a few hours that's going to really expose and shed a lot more light on where we're actually going to go, because now it might go beyond just one computer screen into another. You put on some glasses, and I'll be in New Jersey and talking to one of my patients from Boise, or Flagstaff. So it's going to get better, and we have some really smart people working towards this goal, and hopefully it'll come sooner rather than later.
So just to touch on that a little bit, the reason we chose Arizona, not only because I have family there, but Arizona at the time was one of the most telehealth friendly states, I felt, given the parameters we're working with. We're working with specifically behavioral therapy. So not to say that telehealth is only working for behavioral therapy. It can work for physical therapies. It can work for autism-based therapy. There's a broad scope of options we can go with here, and it's only going to continue to grow. So with that being said, we'll open up for any Q&A you guys might have.
As a user experience
Oh,
designer.
sorry, I'm passing the mic.
I'm a user experience designer. I'm real curious. Well, I'm curious about the technological disparities that people have as well. I mean, my folks live in a rural area. They can't turn on a computer to save their lives. So you've got that issue. But also, I mean, and they enjoy the face-to-face with doctors. So, I mean, it sounds like you start out the visit with a real patient visit and then continue with the telehealth. Just tell me about people's experiences with the tele experience versus the real face-to-face.
Well, we haven't really focused on letting people do it from their home yet. So we're putting the clinics in these areas, in these rural areas, so they have a place to go to. So I can teach you how to log into the program. I can teach you how to go in the process. So even if you don't know how to press power on a computer, that's fine. It's not going to keep you from meeting with us. Our focus is to put these clinics in areas that are underserved. So they don't need to be anything big. You don't need a 3-4 floor hospital. Literally just need about 800 square feet, 2-3 small offices, and good computer equipment, which right now is quite cheap. So it doesn't take you having to have this laptop or an Apple device or that. But a majority of people do have a cell phone. So as handheld devices are more common amongst the entire community, we're going to be transitioning from web-based to eventually iOS and Android. As far as patients coming in and saying, hey, we can go in. My providers are probably there maybe once a month, so it's not gonna, they're not going to be seeing a doctor face to face, but you're in the presence of a doctor. He's able to talk to you still within the parameters of patient provider, regulation and such. So you aren't limited because you don't need a doctor that needs to put his hand on your shoulder. You just want to be able to face to face and tell him, hey, this is what I'm feeling. I'm feeling a little bit of depression, or the medication is no longer working with me how I feel, or it's not doing what we thought it was. Okay, great. As long as they're able to share that 3-5 minute conversation with you, they can give you advice or they can change what medication you're taking. As our focus is medication assisted treatment. So for a patient themselves, they're happy to be able to go into a place and go, okay, great. I am still able to see a doctor, and I don't have to wait an hour to see him. I don't have to wait 2-3 hours to see him.
Yeah, I considered that. I mean, the amount of time waiting for
Right.
a doctor.
And I think for the most part, when I was in Lenore, like they've been around for 3-5 years, so they're patient. I was like, I was in the clinic, I'm watching 30-40 people coming in, and I'm like, how do you guys manage it? Well, you have 3 separate offices. Each provider has their dedicated patients, and it's so timely. So as long as they're doing their counseling, they're able to see the doctor. All they need is 3, 5, 10 minutes with the doctor, and so on. So I think from the feedback I got from certain people in the Lenore clinic, was that they were happy with the service. They were able to go in there and they're not dedicating as much time having to wait for a specialist or having to wait for a provider to see them.
And the commuting time, and I just think of the burden on our healthcare workers during the pandemic. I think it's probably helping them tremendously.
Correct.
So,
Correct.
But
And
you're burning the candle at both ends there, being up late for the.
right. And a lot of it is I know I've met a lot of traveling nurses and traveling providers, and they're going to these areas, and they're there for a month, 2 months, or whatnot. And I know we have a shortage as we go on, so it's even more difficult for them to say, oh, well, let's dedicate some time to these rural communities. Whoever's employing them is going to be like, no, you're not. So it's able to give us so we can keep our population healthy, and not to say, oh, well, if you're that 20%, we don't care about you. That's not the case. So our plan here is to change that, and as people see this model, maybe it'll become more adaptable and be able to serve those areas. Did that answer your question?
Yeah, it's tremendous. Thank
Okay.
you. My mind is just full of questions and possibilities.
To piggyback on that, with regard to addiction medicine, there needs to be infrastructure. There needs to be counseling. There needs to be laboratory testing. So you need a facility that can accommodate those types of needs, and we have that in each of these the facilities. The only difference is that the provider is the actual doctor or a nurse practitioner is on the screen, but all the rest of the facility is there at their disposal. For the purposes of like my other patients in my practice, I have a pain practice, and you'd be surprised how patients really appreciate, when they're on a coffee break, getting a link, and then what would happen is I'll be in my office seeing my patients, and then I'll have a little downtime, and then my assistant will say, hey doc, Ms. Smith is going to see telemedicine, so I'll say, okay, send her the link, and because I'm ready,
Yep.
and then she'll send the patient the link, and then we just have a conversation. She might be in her car, and then I'll be in the office and I'll go through whatever labs or whatever complexity of the visit is necessary, because sometimes, pain management. I have a patient who has back pain, failed physical therapy. I send them for an MRI. They get the MRI done. Now, in order for me to now express what type of treatment that I want to give, I have to review the MRI with the patient. So for them to now come to my office to wait, for an extended amount of time just for me to give them lab results, it's a waste of their time, because they have jobs, they have lives, and sometimes I'll see a patient and the interaction or the purpose of the interaction is so short that I feel guilty that they would have to waste so much time from where they live to drive, to park, to come, to wait, for me to just say, oh, this was the result. So situations like that, it's easy to do telehealth, and they appreciate that. When the level of the visit is a bit more complex, obviously they need to come in, so it's not exclusively telehealth, but in a situation where the complexity of the visit is small, and they can use that time very easily in between their breaks or whatever at work, or I'm telling you, I do a lot of evaluations. The patients are just in their cars, and we have a conversation. They really appreciate it, so it varies, but I try to be as respectful of patients' time, and I feel like you can do that more this way than when they actually come to the office and they're all lined up waiting to see me, and then it all varies. This one needs like a good 35 minutes, but while this one we've been waiting an hour is a 2-minute evaluation, so telehealth definitely helps in that regard.
Thank you for enlightening me. This is fantastic.
And
Really-
to touch on that, the reason why we need a facility, especially in behavioral therapy, is because we do have to collect urine specimens. And that's not something we're taking word on for someone that's dealing with substance abuse. To be able to just like, oh, well, I peed in the cup. And it's there, well, how do I know it's not your 6-year-old son that I know doesn't use drugs that you're submitting? So they still have to go to this site. We still have to get a urine specimen collection. There is people they still interact with. It's just our providers are not there versus being on site.
Thank you.
Yes, of course.
Hi, thank you for this discussion. I just wanted to ask a couple of questions, and excuse me if I missed it in the beginning, but do you all work with payers and what that interaction is like, and about, if you're looking at payment parity, or what sort of, where's SOL fall on the reimbursement scale?
Are you talking in regards to self-pay?
No, insurance companies,
Okay.
private Medicaid in particular. And also wanted to ask, Doctor, from your perspective, what if you need to do referrals, how that process works?
Well,
Yeah, right here, come on.
Sure. Well, to answer your question, the complexity of the visit on a telehealth, it pays less, than it would, like a 99214 is, a complex office visit where you're doing a full review of systems, you do a complete full physical examination. Obviously, you can't do that with the telehealth visit. So where one, let's say the 99214 pays at a certain amount, you're getting a fraction of that. But that's okay, because the amount of people that you can see at that lower complexity of a visit through telehealth, it would kind of make up for that. Now there's the American Society of Telemedicine. They're trying to incorporate more physical findings that you can receive during a telehealth visit, because even in my addiction clinic, we're trying to note, are these patients awake, alert, and oriented? Are there, how fluent is their speech? So there are certain, and what's their appearance? There are certain things that you can pick up from that telemedicine visit without actually having your hands on the patient. So even with that would increase the level of complexity, and with the increased level of complexity, you can increase what you would bill, and ultimately what you would collect. Early on in the pandemic, when they were just trying to get this whole telehealth thing rolling, they made certain rules, and your visit had to be at least 8 minutes in order to bill at one code. And then if it went from 9 to 20 minutes, you can bill at another code. So the insurance companies they're trying to figure out a way to bill appropriately, and to recognize how complex a visit is. But they're still working on it. But fortunately, some good things have happened after COVID-19. A lot of bad things, but fortunately, as a result of that experience, the insurance companies are now forced to take a serious look at how they're going to compensate physicians for telehealth visits, because that's where we're headed. That's where we're headed.
Just to touch up on your question, focusing on Arizona and its own. Private insurers, it's more difficult because a lot of them won't cover this type of service. So we've priced our out-of-pocket pay to be lower than what the insurers are paying for this service area to make it affordable for someone that may be lower income. But we're also working with Arizona. We are in the process of getting permitted and licensed so we can get Access, which Access is a federal funded state-based program. So with that being said, if you don't qualify as financially, you'd be turned into Access, and then Access will be sent over to us, which even when I was looking at the Access billing, our out-of-pocket is still cheaper than what we can bill Access for. So we've made it accessible for someone that may not be able to afford it, so they can still come in and get the medication. It's still cheaper than whatever street drugs they're buying on the street on a weekly basis. I hope that answers your question.
Yeah, that helps. Thank you.
All right.
How is the competition going to come from, I'll call it the low cost providers like a CVS? Because like if you went into CVS at the beginning of the pandemic and they kind of had your minute clinics, like they were like one little, I don't know if you've seen it everywhere, but one little booth over in the corner and you might get some help and you get some limited. I mean, I managed to call up a CVS, tell them I had strep throat, get a codeine based cough syrup for the pain, all without ever going to see someone. Which is kind of crazy if you think about it. You schedule what's a Schedule 4 drug, like just prescribed over the phone, and they based it off of he had it last year too. Which again, it just seems like you can actually really start almost commoditizing in a way that healthcare had never been before. Like a lot of people it takes away like the good doctors necessarily, or I can get this ease of getting. I don't even know who I got on the other end.
You know that is something that exists because you can look online now, which again, access is great, but there is going to come a time where we'll need some type of regulation because you can easily go online right now and find a provider who's willing to just say yes, you have ADHD and just prescribe an Adderall or just say I had a headache 2 years ago and there's someone out there that'll prescribe medical marijuana or whatever. Access is great, but at some point because it does exist, it does happen. And people who are willing to just pay cash to get whatever prescription that they want. So there is going to need to be, and I'm sure it's coming. There's going to become a point where it's going to get much more heavily regulated. But this is even though it's been around for a while, the growth has been somewhat exponential. So the regulation is going to have to intersect it at some point.
Are there things that you, I mean, particularly I guess in your pain side, without being able to see them, how do you draw your line? I guess because there's where you're willing to like go out on a limb and say this is what it is, because there's obviously medical issue like malpractice and things like that. And where I was thinking like, well, maybe you were going to palpitate their back or whatever like that. That might have told you something.
Well, yeah. Anybody could see on the screen and say, hey, I have neck pain or back pain or whatever. So in a situation like that, let's say I've never physically seen the patient in my office, which doesn't happen very often. It happened initially in the pandemic. But you have objective with these subjective complaints. Pain is very subjective. I can tell you right now, I have a 9 out of 10 pain in my shoulder. You won't know. I don't, thankfully, but people can come in the office, in the office and say those things, either even physically in the office or on the screen. We never really know. Me as a physician, it's my job to get a history from the patient and try to tease out certain questions to try to figure out where that problem is coming from. And then if I have the patient in the office, perform a physical exam. But even with that exam, when they lift their shoulder, they can just say, ow, 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 ow. Trust me, it's a tremendous challenge that I deal with on a day-to-day basis physically in the office. And now to add telehealth visit, that also creates that same challenge. But you have the benefit of objective data. If you've you complain of the shoulder pain, okay, you've had physical therapy, it still hurts. We'll get the MRI. The evidence doesn't lie. So if you get that MRI and I just see tendonitis, I know you're blowing smoke. But if I see a rotator cuff tear, or I see a disc herniation that's really pressing on a particular nerve root, I can then say, okay, some of that, if not all of it is true, at least some of it is, because I have the data to support it. But again, physically in the office, they can lie. In the in the telespace, they can lie. For some of the more controlled substances, like in my practice, I don't prescribe any opioids. I find different ways to intervene, but there's some patients who are dealing with chronic pain issues and would benefit from medical marijuana, and I prescribe it. But they would have needed to be in the practice at least 6 months to a year of dealing with this before I would even present that as an option. So you gotta, each person, you gotta take each patient in each situation separately and look at the entire clinical scenario, and over the course of your time with your relationship with the patient, and then figure out what treatments are necessary.
So you really made these decisions though based off your own experience for what there. So to your point, someone can push the envelope and get away with a lot.
Oh yeah,
So
absolutely. But there's only so much that you can get away with before the DEA comes knocking on your door.
it kind of makes me wonder, being a lawyer, the law firm situation is the rainmaker, right? And the rainmaker meets that client, and especially many times does that initial diagnosis on how we can provide everything for you, and then that client never sees that doctor, that guy again, that lawyer, right? Then he gets pawned off to the other one. So you could almost see the situation where you have the name wherever he is. Maybe he's in the Bahamas on vacation all the time, but just logs in, and then satellite based, the people that he's going to have work on it that are almost working for him in a way.
That can happen. I haven't seen it, but I'm sure it can exist. And probably does somewhere, but I personally just haven't been around to it. But it's definitely something that's possible.
I was thinking about it for whatever reason. I saw some Netflix. It was plastic surgery, and you could see how people want to go to this one plastic surgeon who's always booked and charging whatever. Well, now he can I'm going to do all this, and this is what we're going to do, and here's the guy performing your surgery at the kind of last minute swaps out your surgeon.
But on the flip side, you have robotic surgery where as it stands right now, you can have I'm not a urologist, but a urologist can remove your prostate, or a general surgeon can remove your gallbladder robotically. So they'll have you'll go to the OR, anesthesiologist will put you to sleep. The surgeon, between the physician's assistant and the surgical tech, they'll place the instruments in the places necessary, and then as it stands right now, the surgeon's in the other room, and the surgeon is now manipulating the probes and the knives and all the other things that they're using, and the trocars that they're using while they're in another room. It's a very intricate surgery with less loss of sexual function. Because it's a very precise way of removing the prostate, as an example. Surgeon's in the other room. But technically, if the technology is good enough, that surgeon could very well be in the Bahamas and do that same type of surgery as long as the technology is up to snuff. So on the flip side, yeah, you can have that, but what exists right now is a beneficial scenario where the surgeon does not have to have their hands inside of that patient's body, but still able to perform a really amazing surgery.
Just to touch on your question here. So in regard to addiction specialty, it's highly, highly overviewed by the Drug Enforcement Agency. So it's not something that's just, you got someone to, it's not a pill mill. Because when this person comes in, let's say John Smith comes and checks in Flagstaff office, and he goes, "Hey, I need my medication. I'm using buprenorphine, which is a narcotic, which again is not something that's just given out like candy." That person's checked in. There's a DEA website, so you're going to be able to see, oh, well, John, you were just in Boise last week, and you already picked up 2 weeks worth of medication. What are you doing here now? So they've cracked down on it quite a lot the last 5-10 years. So it's not just someone prescribing medication at will and then going to the clinic or CVS at the other corner that's grabbing that. So with the urine talk, these sites with the urine specimen collections that we collect, I'm able to see if you're taking the buprenorphine or if you're just crumbling a little bit, put it under your fingernail and then peeing in the cup and it goes in. Because I'm able to tell the difference between 2,000 milligrams of buprenorphine versus 20 to 30 milligrams that's coming through your urine collection. So it's something that we're able to see and see fraud in versus someone that's coming in and is like just shuffling the pills on the street and selling them out and then going to another clinic and getting more pills and doing the same thing. So preventative for that type of thing. We had one more question.
So many questions keep popping
No,
in
it's
my
fine.
head,
That's
but-
why we're here. That's why we're doing a 30-minute Q&A.
Let's speak to the technology you're using for telehealth. Are you using Zoom, Teams? What are you using? What do you find? What are the products out there right now that are helping you build these clinics?
Okay, so for our clinic specifically, we're using Doxy, and then they're able to check in, and it's similar to Zoom, but more secure, and it's based for telehealth, telemedicine. So I'm not as well versed as I felt like I'd be in it because I'm only 6 months into this specific type of program and software. Do you want to touch on it?
Yeah, DoxyMe, it's encrypted and it's HIPAA certified, and we recreated an account, and each of the doctors and healthcare providers has an account, and it creates an office. And we have our staff in our respective offices that would then open a clinic. So they'll tell me, Dr. Moyes, Mr. Smith is in Lenore too. So once I go into DoxyMe, I'll see the dashboard, and there'll be other clinics that are open. I'll know that my patient is in Lenore too, or that day I'll have all of my patients being seen in Lenore too. Meanwhile, my brother could be seeing his patients in another one of the clinics. But again, it's HIPAA certified and encrypted, and I'm not familiar. I mean, I know Zoom is great for meetings and those types of things, but we've been using that even pre-pandemic, and it's been successful. So I don't know what else is out there, but Doxy.me is the and beautiful thing about that, you can use it on your laptop, you can be on your phone, as long as you have a good enough internet connection, because I've had clinic while I'm in Hong Kong, the hours were terrible, but I was able to see my patients, and then the EMR that we use in our practice is Practice Fusion, and we're able to do our evaluations, document our encounters, and prescribe our medication using that platform. Doxy.me. Doxy.me. And practicefusion.com.
Thank you guys for an incredible presentation on a really important area. We advocate for telehealth, being a company here in Idaho, we said for autism. And I just have believed in this for 20 years, that access for kids with autism or folks facing, behavior challenges, maybe because of opioid misuse or whatever, telehealth could do a lot to change the trajectory of what hasn't worked up to now. So the case where if a CVS doc is making a decision, it's mostly because there's no expert for them to be able to run the scenario by. With telehealth, an expert like Dr. Mays would be available for the CVS nurse practitioner to be able to make a better informed choice. And just know, in Idaho, the psychiatrists, the folks who deal with opioid misuse, they want to make access to those primary care docs or nurses that are out in the rural areas who are having patients coming to them and needing help telehealth, the way you're describing it, is the way they're going to get better decisions, better prescriptions, because an expert like Dr. Mace is able to guide a counselor or the psychologist or whoever's there locally for the family, where they have to prescribe when they don't have expertise that way. And so we're at a place where telehealth is going to address that. It's going to reduce the amount of medication abuse. And it's not because our providers are doing it for any, hardly ever for fraud or whatever. They're trying to help patients with a really tough issue. And I'll tell you, as a parent that has a child with autism, very severe, for me to be able to see somebody when he's having a behavior meltdown and be able to get input about a medicine, to drive over the mountain from our farm in Emmett to go see his doctor in Boise is hardly ever added any value to it than the immediacy of being able to reach a doctor via telehealth to address the issue there on. And there is good research about where a telehealth will give the digital information for Dr. Mace as good as if somebody was in the office presenting in another way. You've seen a lot of the research too, that there is value with naturalistic data coming from another site for you to review, as you were talking about yesterday very effectively. So we're obviously big advocates. UX is important because your clinical workflow needs to be support how you use the system, how scheduling makes your clinical time available. And all that's kind of being developed in these Doxy systems and others as well. So I hope that helps.
Thank you for touching on that, Ron. Definitely elaborate. Well, that concludes this talk. Are there any more questions? Thank you guys all very much for joining us.